And I've been wanting to do this Microbiome Masterclass for a while. We did a short version of this at the Egypt Symposium at the BSG last year, and it was really well attended, and people were clamoring for more. So I'm delighted that we can finally get this one off the ground. I think the problem with the microbiome is that there's a huge amount of enthusiasm about it. So everyone's talking about it, everyone's really enthusiastic about it. But whenever I go to see a talk about the microbiome, I'm always left slightly baffled. And I have this kind of Brian Cox moment where the people giving the talks seem to like to make the microbiome seem unfathomable, as if the people giving the talks are the cleverest people and they're the only clever ones who can understand it. So there's a huge gap, I think, between the enthusiasm that healthcare professionals have got from the microbiome and then the science in between it. And we're going to try and plug that gap tonight. But there's also a huge market in digestive health at the moment. So the market is worth about £13 billion globally. And out of that, there's very little evidence to see which of these products actually are science-led and work. So lots of money is being spent on probiotic enzymes, prebiotics, and so on. But again, it's not really strongly based on evidence. So I've tried to break this down tonight into what I think we need to know about the microbiome. And the first thing is that microbiome research is incredible, but only a fraction of it seems to translate into clinical practice. And many common GI treatments that we use have adverse effects on the microbiome, but these are not really talked about. There's a lack of education and training across all the healthcare sectors. And patients are really frustrated by this and are now seeking out their own testing and their own treatments. And this is frustrating for us clinicians because the results of most of these tests are uninterpretable. So first, what we need to do is make the microbiome somewhat understandable, and that's going to be the first talk from Malvina, and she does an amazing job of this. Second, we need some objective and actionable tests with recordable outcomes that help us make sense of what the microbiome is doing. And third, we need new treatments that are microbiome focused and potentially curative rather than symptom-based treatments that are just basically masking symptoms. So what are we going to do about it? At Functional Gut, about 18 months ago, we set up a free-to-use consumer advice website called Tummy MOT. And the idea of this was trying to give people free advice and preventative tips. So no-nonsense digestive health information, education. We do unbiased product reviews of things like probiotics, prebiotics, supplements. And we engage with the companies to get their best evidence of the science they've done and try and promote best practice. We help to do research into these products, and we have an active research community from people who subscribe to Tummy MOT, participate in these trials. And if people are looking for tests, we direct them towards functional gut clinics so they can go on a diagnostic health journey. And in 18 months, you can see how popular it's been. We've had over 4.2 million social media views from our educational videos. We've got over 10,000 Instagram followers. We've had over 3,500 research database signups. And we've got 5,500 email subscribers with a high engagement rate. And what we've also been doing over the past year or so is to have these free virtual education events. And in the next 6 months, we're hoping to have some in-person training events, both in the north and the south of England, maybe in the third and fourth quarter of the year through our Functional Gut Academy. So we're trying to plug that gap between what we do in secondary and tertiary care and what happens inside kind of primary care and consumer. So hopefully this journey we have tonight is going to take us through that. So Malvina is going to give us the first talk on understanding the gut microbiome. Jordan is going to talk about microbiome testing. And James is going to talk about the future of microbiome therapy. If anybody wants to ask any questions, please click on the Q&A section, which is the question mark, and don't go into the chat. And all registrants will be sent a link to the recording if you want to share, and I'll introduce you. So I think I've known Malvina for about 10 years now. It seems, doesn't seem that long at all. But Malvina's a nutrition scientist with a PhD in nutrition and medicine, and she currently serves as the head of clinical development at ADM Health and Wellness. She's been actively engaged in medical research for over 15 years and has a recent focus on collaborating with both academic and commercial research centres. Malvina and I have collaborated on a study in healthy volunteers with BioCult, which had some amazing results. and she's gone from strength to strength in her position, and I can't wait to hear what she's going to tell us.
Thank you, Anthony. Thank you, Anthony, for the invite and opportunity to join you tonight. And thank you to everyone who has joined us live. I know it's a late hour, so I'm going to try to keep it short and focused. But as Anthony mentioned, my role today is very simple: to cover the basics, make sure that when we talk about microbiome-related terminology, we always mean the same things, and to set the scene for the future of the research, of the conversations, the developments, and also for presentations for James and Jordan. So thank you, Anthony, for a very kind introduction, and I will jump straight into the overview of my presentation today. So we're going to start with the basics, the key terms and fundamental concepts that allow us to discuss microbiome and microbiome research. Then I'll go into talking about microbiome in disease states and focus on those conditions where we have solid evidence, after which I will move into discussions about the microbiome and medications, their interactions and impact of one onto the another. And after that, I'll go into modulating microbiome opportunities and whether there is any sense in that approach. So let's start with a very basic terms. And I think when we talk about the microbiome, we need to make sure that everyone thinks the same thing when we talk about the microbiome. So when we focus on all of the microorganisms, whether they are bacteria, fungi, or viruses, we're talking about them within a specific environment. And when we focus on human microbiome, we would be referring to a specific niche or a system. So then we refer to mouth microbiome, skin microbiome, or digestive tract microbiome. But we can go more specific. We can be talking about upper GI microbiome or a colonic microbiome. And in every aspect, we can zoom in or zoom out and get focus or a little bit more of an overview on the human microbiome. But that's one of many, many terms that those who have interest and have been keeping track of the media and scientific coverage on microbiome research, there's loads of other terms that you have come across. And some of them are very self-explanatory. Some of them are very complicated scientific terms, but I'm just going to cover those that will help us to talk about this topic and make sure that we all understand the same thing. So, of course, when we talk about the microbiome, Anthony already mentioned there are lots of probiotics, prebiotics, and other products that are commercially available on the market. And even though those terms have been in use for many years, they often misused and used interchangeably. But very simply, probiotic are the live organisms, the microbiome, that when provided into the microbiome in the adequate amounts, they confer benefit to the host. Prebiotic is the food for those bacteria, while if we put the two together, we create a synbiotic. Now, recently you would hear a new term, postbiotic, and that's both the inanimate version of the probiotic bacteria strain, so that could be a heat-killed bacteria, or metabolites and components of the cells of said bacteria or metabolites of some food. So it's not an active live cell like a probiotic, but inanimate, inactive version of it. And yet, when provided in adequate amounts, it also can confer benefit to the host. Dysbiosis is a little bit more tricky when it comes to defining it, because when we think about the dysbiosis, we need to think about every consideration of other than healthy microbiome. So whether it's low abundance of bacteria, whether it's low diversity of those, or presence of pathogens, all of those would be considered dysbiosis. So anything that is not a healthy microbiome. And when we talk about bacteria, we often talk about species and strains, and those, trust me, are being used interchangeably, and that is quite challenging and difficult, especially for people who work with species and strains, and especially when you're trying to make sense out of the scientific data that you might be reviewing to judge your own, to make your own judgment on any products or scientific evidence that you come across. So I'm a foodie. I love comparing everything to food analogies. So I have created this small story. So bear with me. imagine that your management requested a very simple thing. Go and bring me cheese. Would you know what cheese to bring? In most cases, we would fail to bring exactly the thing that the person has asked us to do, unless they give us a little bit more indication. And that story would very much go along the pathway of going from the phyla, genera, species, and strains. So think about a cheese being the phylum, a very, very broad term that describes lots of different products in that category. And if we then drill it down to, well, actually, that person meant cheddar cheese, that's a little bit closer, but still you have a big variety of maturity of cheddar and brands available. If we think about species, the bacteria within the same species would be named by the same name. So, for example, here, Lactobacillus infantis. But you can have two Lactobacillus infantis, and yet they are not the same. They are not clone of each other. They're more like siblings. They will provide the same functions, but not identical. Only when you go to the strain level, you are talking about that very specific bacteria and exact copies of the same bacteria. Why it matters? Because only when we're talking about a very specific one exact bacteria, we can say that evidence that we have seen for that bacteria can be assumed and hoped to be seen again. If we say that Lactobacillus infantis PXN27 has shown to be beneficial in children with infant colic, then we can say that because that's what research has shown. But we can't say that every Lactobacillus infantis would therefore be beneficial to children with infant colic because we don't have that evidence and they might not work in the same way. So now onto the fundamental concepts. I think the first one is pretty self-explanatory because diet determines the microbiota. We are what we eat, and that even more applies to our bacteria. The change in our microbiome over the centuries was related to two tremendous changes. One about 10,000 years ago when we moved from hunter-gatherers to farming, and it was a massive shift in our microbiome at that point. Then it remained relatively stable for thousands of years. And the second dramatic shift was when the industrialization kicked in and we started using processed flour and sugar. That led to a huge shift in our microbiome and is still tremendously impacting our health. There's a lot of evidence that feeds into this concept, but in interest of time, I'm going to just present one research that very elegantly presents that our diet directly determines what bacteria we've got in our GI tract. So this study looked at two cohorts of children, one in Italy in Florence and one in Africa in Burkina Faso. And for simplicity, let's just focus on the outer circles of the graph. So when we compare the amount of blue, which represents Bacteroidetes, and red, which represents Firmicutes, we can see that proportion of the two is very different between the two cohorts. And why does that matter? Well, because amongst the bacteria that are together called Bacteroidetes, there is a set of bacteria that can hydrolyze cellulose and xylan. And why does it matter? Well, because xylan is the plant cell wall's component, and if you can break that down, that allows you to utilize your plant-based diet to a greater extent. Where children who lived in Florence in Italy had much smaller amount of those bacteria and much smaller proportion of the Bacteroidetes to Firmicutes because their diet was not as rich in plant products as those in Burkina Faso. Now, fundamental concept 2 is related to our health status and the fact that our microbiome changes with our health. And some of you might be familiar and heard about the American Gut Project, which recently was rebranded as Micro Rosetta Initiative. And one of the coordinators of the project, Michael Pollan, tests his samples on a regular basis whenever he feels something changes. So here on the graph, on the axis, you can see that each line represents a different person and different colors represent different phylas of the bacteria. And you can see Michael Pollan in his good health, and then he fell unwell and started developing an illness, and his microbiome shifted on that axis. Then he has been treated, and after the treatment, his microbiome yet once again has shifted dramatically to a completely different proportion between the different phyla of the bacteria. So we need to remember the microbiome is a very dynamic thing. It's very responsive to our environment, to our lifestyle, to our health status and treatments. And it's never the same. It changes even between day and night. And then the fundamental concept number 3, which basically is the reverse. Our microbiota changes with health, which we established, but also it influences our health status. And we know that because there's a whole range of metabolites that are produced, and their existence in our human body is dependent on the presence of those bacteria. And if those bacteria are not available, those metabolites will not be produced. And that has often tremendous impact because conversion of bile acids, we'll discuss later on how important that is. We know that short-chain fatty acids have important role in maintaining intestinal barrier and health of our gut, and so on. Many examples have been established over the years linking metabolites with specific bacteria and showing that without those bacteria, we don't get those metabolites. So let's move on into the role of microbiome in disease and impact of medications on the microbiome. So one of my favorite examples here is looking at C. diff infection and the impact of our microbiome. And there are 2 scenarios. One is that we have someone who has healthy microbiome with the high numbers, the high abundance and diversity of commensal bacteria. And why would that matter when it comes to C. diff? Well, if we look at the primary bile acids that are synthesized in our body, their conversion from primary to secondary bile acids is dependent on the presence of commensal bacteria. Why is that relevant to Clostridium difficile infections? Because primary bile acids trigger spores germination and convert spore C. diff into vegetative cell. Now, you would say that might not be good for human body, but that's where the mechanism protecting us is being triggered and provided by the bacteria, because the secondary bile acids have inhibitory effect on bacteria, the Clostridium difficile bacterium, and inhibits their ability to multiply. So what happens here is that because of the right proportion between primary and secondary bile acids, C. diff spores are triggered to germinate, are provided as a normal bacillus in its vegetative cell, and cannot multiply, hence ultimately dies, and cannot trigger the full-blown infection. But if we reduce the amount of commensal bacteria or change the profile of those bacteria, we have still available primary bile acids, but conversion to secondary bile acids can be inhibited, or insufficient amounts of secondary bile acids are available. And then what we have is other metabolites like succinate. And what happens here is that primary bile acids trigger conversion of C. diff spores germinating into vegetative cells, which then are not inhibited from multiplying, and that's when the full-on infection develops. And we know that this disturbance to microbiome could happen for many reasons. One of them would be use of antibiotics. It's pretty well evidenced that use of antibiotics has negative effect on bacteria, both the pathogens, but also collateral damage to commensal bacteria. But this paper in 2018 studied 1,000 different drugs, and they focused on commensal bacteria, not on pathogens. And what they have found is that not only antibacterial drugs, which are here in green, have negative effect on commensal bacteria, which would be expected, but also anti-infective drugs that target fungi, parasites, and viruses have also direct negative impact on at least one commensal bacteria. Now, what is very interesting is that in this research, they have shown that human-targeted drugs, so drugs that were developed to specifically target human cells, have also shown that at least a quarter of them has direct impact on microbiome and commensal bacteria, and 40 of those had a broad spectrum effect on 10 and more commensal bacteria in the testing. And those numbers, those scientists have stated, are underestimation of what actually happens in the human body. So what can we do about it? Anthony mentioned we do have a lot of evidence and a lot of data, but it's really hard to translate into practice. And here, again, we don't have a direct indication what to do, but the best thing would be consideration. Do we need the medication? Do we need it for that long? Would it have impact on gut microbiome? And if so, are there any alternatives? Could we do that treatment for shorter? And just to consider that if we provide certain medications, that will come at a cost to our commensal bacteria. Now, there's also an option of repurposing those drugs because some of them have targeted commensal bacteria, could also be used as in novel drugs. But that's a whole new conversation, so I'm not going to go in there. Now, some of you might be interested in what the mechanical bowel prep does to microbiome, and two things to consider here are that microbiome bowel prep will wipe out majority of the microbiota in there, reduce the diversity and bacterial load dramatically, as you can see by the brown and red lines on the graph. But numbers will rise back very quickly. But what will not rise very quickly is the diversity, which means that this gap, the niche created by wiping out diverse microbiome, will be replaced with less diverse microbiome, and there is a risk of providing that niche, that empty space for pathogens and bacteria that wouldn't necessarily be welcome in that space. So we always need to consider that it would have impact, although if you compare it to the impact of antibiotics, it is smaller because antibiotics impact is much longer, and very often that diversity, as seen by the blue line, cannot go back to the levels seen prior to the use of antibiotic. And all of those aspects about the importance of microbiota in the treatment, their interactions with medications, their impact on disease, have led to considering gut microbiota as one of the relevant components when individual variability in drug response is discussed and considered. So for all of those who prescribe and for all of those who provide healthcare advice to patients, it's always worth to have a little stop and think if we can do something that will prevent and protect our microbiota. Now, I did mention that drugs have some impact on microbiome, but also microbiome has impact on drugs. So drug microbiota interaction is an area of now huge interest, and then more and more studies looking specifically into different drugs and different bacteria species and their interactions. And this is a paper from 2023 that I would highly recommend because each one of you can find an area of drugs and treatments that could be relevant to you. So very worthy paper. But I'll provide you just with one example why we know and why do we need to think about that interaction between the microbiome and drugs. So sulfasalazine, we know it's not rapidly absorbed in the upper GI tract, and we know that it's serving better patients with ulcerative colitis than with Crohn's disease for that very reason. But we also know that it's broken down by gut microbiota in the colon and converted from inactive form into 5-ASA and sulfapyridine. Now, how do we know that, and why can I say it almost for sure? That's where the research has very elegantly shown that if we take germ-free rats and give them sulfasalazine, after going through a germ-free gut, we still get sulfasalazine in fecal samples. But of the same germ-free rats are then being given a cocktail of probiotic strains from Lactobacilli and Bifidobacterium species, they then recover ability to convert sulfasalazine in sulfapyridine, and samples of fecal matter then were with the sulfapyridine in it. And also sulfapyridine in reverse promotes bacterial production of butyrate. So if we have sulfapyridine, we generate butyrate, which is also good for colonic health. So if there is relationship between microbiome and drugs and health and disease, can we modulate microbiome for our advantage? And that question has been asked many times and in many topics. And what I would like to remind you is that it's not only which product we need to think. Here you've got a summary of research when in 2017 meta-analysis suggested that it's not only question of can use of probiotics help to reduce risk of Clostridium difficile infections. What it has concluded is that it's the timing when it's used that matters the most, and using probiotic alongside antibiotic and starting it within 2 days of antibiotic was reducing the risk of developing CDI by 70%. That was reduced to only 30% risk reduction if probiotic was started later than 2 days after antibiotic. So it's all about the timing. Now, research in modulating microbiome is vast and covers many indications, but now we're getting a lot of focus on gut-brain axis. And historically, of course, use of probiotics would be focusing on GI health, where now with the gut-brain axis, our recent publication in collaboration with King's College London was related to a project looking at patients with depression. And in this study, we actually randomized patients with major depressive disorder who were on antidepressants. And they were given a blend of 14 strains for 8 weeks. Numerous different outcomes were studied looking at their depression and anxiety. And I know this is a busy slide, but bear with me. If we just look at the top 3 graphs, you'll see that those are 3 different questionnaires looking at baseline week 4 and week 8 results for probiotic in orange and placebo in gray. And you see that consistently for all of those questionnaires, whether that's self-reported or clinician reported, whether that's depression or anxiety, the same pattern is seen. A statistically and clinically important reduction in the severity of their symptoms. And as you can see, numbers on the right, that was 30% reduction for the HAM-D and IDS, and 48% reduction in HAMA score at 8 weeks. Now, the bottom graphs, that's the CGI questionnaire, so Clinical Global Impression Score, and it shows you how many of those participants have seen improvement from their perspective and a clinician-rated assessment of efficacy of this product, which has led to clinically meaningful reduction in the scores. So by giving those patients with depressive disorder a cocktail of probiotics, we have seen increased efficacy of their medical treatment. One other study that I wanted to draw your attention to is comparing probiotics and postbiotics. And at the very beginning, I said postbiotics are becoming more and more interesting and relevant. And this is a study where directly we studied probiotic and a postbiotic of the same strain, and very classic model of IBS diarrhea predominant patients looking at numerous outcomes. What we've seen is that whether you're using a probiotic marked in purple or a postbiotic marked in orange, on the left graph, you can see that the change in severity symptom score was dramatically improving from day 28 to day 84, and was statistically and clinically higher than in placebo groups, with changes of 60%. Now that, what is most important from my perspective, has translated into improvement in their quality of life of scores at the end of the study, increasing to 20 points and 25 points in the postbiotic groups. And bear in mind that for that questionnaire, the clinically meaningful improvement is seen at 14 points. So whether it was a probiotic, a live version of this probiotic strain, or whether it was a postbiotic, a heat-killed version, we still have seen improvement in symptoms and improvement in quality of life. which opens a whole new avenue when it comes to research in the space. So just to summarize, if we think about our microbiome, medications are impacting the microbiome. Our life every single day has an impact on what our microbiome looks like. So what we can do is to try and protect it with a diverse diet, reduction of environmental factors, and reduction of unnecessary use of medications. Though when those medications are needed for treatment of disease, then there's chance to consider how to prevent reductions in richness and diversity. But sometimes that is not possible, or that has already happened. So then there's a talk about restoring the microbiome and trying to bring it back to its richness and diversity. And that's something that we're going to be talking in the next presentations today. So going back to what was the overview at the beginning here, just a few take-home messages for you, that we reshape our microbiome every single day. And also, because our microbiome is so relevant to our health, it has now been considered one of the main components for individual variability in drug response. The medications and the medical interventions have impact on microbiome, but the scale and longevity of those impacts is different depending on individuals and treatments, and still does not provide us with enough clinical guidance. But we are increasing understanding of the role of biotics and modulation of microbiome in health and disease, and how by modulating that we can help patients to minimize their symptoms, improve their health, and prevent changes that could come with negative side effects. So with that, thank you so much. And following Bonnie Bassler, who I always refer to as Bacteria Whisperer, remember that by weight, there may be more human cells, but because by numbers, completely misrepresented her words. By weight, you are more human than bacteria because your cells are bigger, but by numbers, it's not even close. So with that, thank you, and I will pass back on to Anthony.
So you can stop sharing. Marvina, that's fantastic as always. Really good guide through there. I mean, just time for a couple of questions. If you're, we get asked all the time by patients whether they should take a probiotic daily just as a preventative measure. It can be expensive. What would the recommendation be? Should you take this if you're wanting to prevent it, or you're going through a difficult time, or you're poorly, or should this just be like taking a vitamin?
It all depends. Why would you be taking a probiotic, and what are you taking it for? And again, there's no one solution that serves everyone, because different diet, different lifestyle, whether but those people are taking any daily medications, all of those would factor into the decision whether it's better for that individual to be taking probiotic daily or at times of need. And it might be that if you live a healthy lifestyle and have diverse diet, it is only periods of time that would be beneficial for you to take those probiotics. But if there are chronic illnesses, if there's a chronic use of medications, if there are factors in your life that on a regular basis could be considered as detrimental to your microbiome, then that preventative measure of taking it more long-term could be advisable. And sometimes it's a matter of balance between what would be best and what we can afford, or what people can afford, and having periods of using probiotic, then a little break, and then bringing them back so that it's more financially feasible is also an option.
One more question about things like a low fermentable diet. Here we go. It's if diet alters microbiota, presumably daily probiotics would do the same. Would that then impact how effective these strategies are in treating disease?
So we need to remember that the impact of most probiotic and symbiotics on the market is transient. We are not able to colonize our microbiome with new bacterial strains once we're grown-ups. So the way your microbiome looks today has been mostly determined within the first 10, 15 years of your life. And later on, it does shift and change, but mostly it can be detrimental change rather than a beneficial change. So if we're taking a product daily, then the effect will be visible if that's the right intervention that we have chosen. But if you take it for a year and stop it for a year, after that break, you're not going to see any of those strains in your gut anymore. They're not going to be able to provide you with any beneficial effect, because the so-called washout period, so the time after which you don't really find those bacterial strains in the guts, will vary, of course, depending on many factors. But usually after 3 to 6 months, you're not going to find any of those strains in the gut anymore.
And Jordan, did you have a comment there?
No, I was just agreeing with Malvina in terms of a probiotic alone is not going to be enough to colonize the microbiota. Perhaps James later will tell us if it's possible by other means. But shall I get into my talk? Is it a good time to?
Yeah, we're just going to give. Yeah, I think because of time, I won't be able to answer that one. We'll answer that one from Archie offline. So bear with me there, Archie. So yeah, Jordan, I'll do your introduction. So Jordan, I've been delighted to have Jordan as my colleague for the past 7 years. Jordan was actually the first person to be recruited into our graduate training program and has since gone on from strength to strength, doing his accredited GI physiology course, MSc, and is now doing a PhD at John Moores University in Liverpool, looking at the effect of gut health and sport. So Jordan's going to be talking about microbiome testing versus breath testing, and hopefully telling us that it's what the microbes are doing that matters. Okay, Jordan.
Yeah. Thanks, Anthony. So yeah, Malvina did a great job of telling us what the microbiome is. And in this talk, I really want to dive into the clinical utility of stool microbiome testing in our practice and why I think that actually breath testing might be more clinically useful in terms of helping us to target treatments. And then briefly at the end, we'll discuss what the future of microbiome testing looks like. And as we've just said, it's in what those microbes are actually doing. So my declarations are that I work for the Functional Gut Clinic and we do provide both breath testing and microbiome testing. So stool microbiome testing really took off after the Human Microbiome Project data was released over 10 years ago now. And since then, it's everywhere. So I did a bit of digging and I Googled stool microbiome testing UK. And on the first 10 pages of Google, I saw at least 47 different companies offering microbiome testing. And some of them weren't even clinical entities. There was fermented food companies providing this, a diabetes shop, and even a microbiome test available on eBay. So last year, this data was published from some researchers where they looked at 6 different commercial kits from the Europe and one from the US. And they found significant heterogeneity in terms of costs, turnaround time, but more importantly, on methods. So how the samples are taken, but also how they're sequenced. And in commercial testing, there's 2 primary ways that these are done. It's with 16S or shotgun. And the main difference is that shotgun allows you to go deeper. So you can look at more lower abundant taxa in the microbiome. And some of these lower abundant taxa might actually be biologically meaningful to us. So you can see in the figure there in the green, that's how many more phyla and genera that shotgun is able to pick up. So this is probably what you want to be doing, at least in terms of research. However, commercially, I don't think it matters too much because the recommendations that you can make based off these testings are pretty vague. So what a stool microbiome test can tell you is richness and diversity. And based on that, if there's low diversity, we can tell you to eat more plants because more plant diversity equals more gut microbiota diversity. And there's some recent data showing that a diet high in fermented foods is able to increase gut microbiota diversity in a short space of time with 5 to 6 servings of these a day. And we replicated this as a social media experiment last year that we dubbed the Fermented 5, where myself and 4 of my friends through Tummy MOT did 2 weeks of 5 servings of fermented foods every day. And a few of us saw significant improvement in diversity. It can tell you about the abundance of some beneficial microbes, particularly short-chain fatty acid producers. And if these are low, then we can recommend things like prebiotics that have been proven to increase the levels of these bacteria, such as resistant starch, hydrolyzed guar gum, and galactomannan, which is a derivative from fungal cell wall. It can also tell us about the abundance of pathogenic bacteria and other pathogens like candida and parasites. And then when we see this, do we really want to be giving people antimicrobials? Probably not, because when we look at things like candida, for example, we actually see that there's similar levels in the gut, in the stool of healthy people without GI symptoms as there is in people with GI symptoms. And then when it comes to parasites, these are very, very rarely detected on stool microbiome testing. And if they are, it probably does require escalation 2 treatment. And similarly, we can pick up things like methanogens. These are archaea like Methanobrevibacter, and hydrogen sulfide producing bacteria like D. sulfibrio. Again, these seem to be a normal part of the gut microbiome. So when we see these on stool testing, we can't really infer much from this. And there's a few other things that stool microbiome testing can't really tell us either. And one of those is intestinal permeability. Now, I've seen a lot of lab reports report the levels of zonulin. So zonulin is something that basically regulates the tight junction proteins in the gut. But we know from data that zonulin is a really inaccurate biomarker of intestinal permeability. So you can't infer that from this in stool. It can't tell us much about the luminal microbiome. So stool microbiome pretty much is, the colon, distal colon. And it doesn't tell us about the microbes within the mucosa, and it doesn't tell us about the microbes within the small intestine. And there's some data from the Reimagine study where they've been sequencing the small intestine, and you can just see there from that figure how starkly different the sort of abundance of microbes are in the small intestine when compared to the stool microbiome. And lastly, and most importantly, it can't really tell us what those microbes are doing. Okay, with shotgun, you might be able to get some inference into some of the genes that these microbes have, but it's not really telling us, what they're doing. And just to revisit the physiology of metabolism, again, quite briefly, we obviously ingest a lot of different nutrients, and these are broken down in our gut with the help of things like bile and pancreatic enzymes. And then these are absorbed across the 15 feet of our small intestine. And then anything that's undigested arrives to the colon, where it's metabolized by our gut microbiota. And there's an increasing gradient of bacteria throughout the GI tract. So in the first part of the small intestine, it's around 1,000 of these cells per milliliter. But when you get to the proximal colon, we're talking 10 billion, 100 billion bacteria per milliliter there. So there's a lot. And these bacteria are synthesizing a whole host of products and metabolites when they feed on our undigested foods. These are things like gases, hydrogen sulfide, methane, hydrogen, short chain fatty acids like acetate, propionate, butyrate, things that are good for us like vitamins, things that are not so good for us like toxins, and also signaling molecules like neurotransmitters, serotonin, hormones, things like GLP-1, and VOCs as well, which are bacterial signaling molecules. And there's this whole cauldron of activity going on in the gut. And what we're looking at here is basically what the microbes are doing, but there's not really been any means to look at that apart from traditionally hydrogen and methane breath testing. So hydrogen and methane are exclusively produced by bacteria in the gut, so not by human cells. And the way breath testing works is the bacteria produce these gases, they're absorbed across the intestinal epithelium, and they're transported from the blood to the lungs where they're exhaled in breath, and then we can detect these using technology. And one thing that we can detect using hydrogen and methane breath testing is SIBO. So SIBO is an overgrowth of bacteria in the small intestine. And if you remember, there should be relatively low numbers there, but with SIBO, it's higher than the 1,000 bacterial cell count per mil. And what happens with SIBO is you get the premature fermentation of carbohydrates, and the primary symptom of SIBO that we see in data is bloating. And at the minute, there's two different substrates we can use to diagnose SIBO, glucose and lactulose. Glucose is a monosaccharide. It's absorbed in the first third of the small intestine, so primarily in the duodenum. Lactulose is a non-digestible sugar that is made of galactose and fructose, I believe, and we don't produce any enzymes to break this down, so only bacteria can. But this also means that it travels the whole way through the small intestine to the colon, where it's ultimately fermented by the microbiota. And there's some pros and cons to using both of these sugars. So with glucose, it's more sensitive, in that if you get a positive result with glucose, you can be more confident that it probably is SIBO. With lactulose, it's more specific, so that if you get a negative result with lactulose, you can be more confident that it probably isn't SIBO. But then vice versa, we have the fact that with glucose, you're more likely to get a false negative because it is absorbed in the first third of the small intestine. If there's overgrowth further along, you may miss that. And with lactulose, in someone who has rapid transit, that lactulose arrives at the colon quickly and it's fermented by the bacteria there, producing a rise in gases. Could that be a false positive? Well, we prefer to use lactulose because it is not absorbed. So we know that it's going to arrive to the colon. We're actually going to get some useful information from that. And what's interesting is that the UK and EU guidelines don't really recommend lactulose breath testing or breath testing in general for IBS. And this is despite the fact that we have data showing that the lactulose breath test predicts response to treatment in people with IBS-D, to the point that if you have a positive lactulose breath test, you're more than twice as likely to respond to rifaximin than if you didn't. And lactulose breath testing, we know, can also predict response to low FODMAP diet, which kind of makes sense in that the low FODMAP diet is aiming to reduce fermentation levels. But when we look at a breath test, this is what we often see in a positive result. So we see a rise in 20 parts per million of hydrogen before 90 minutes. But then we have people arguing whether this rise is in the distal small bowel or is it in the proximal colon. And we say it's a moot point. The argument doesn't matter because wherever that rise is before 90 minutes, it predicts response to treatment. And also we say don't ignore the second part of the test either, because if this correlates to symptoms, and I'm going to show you some data shortly that we're about to publish at Functional Gut, that this area of fermentation in the proximal colon can relate to symptoms in our patients. And this is from the HMBTQ study that we've just done in over 700 people who were undergoing a lactulose breath test. So we gave them a questionnaire looking at their medical history and symptoms. And we saw that this rise of 20 parts per million in hydrogen within 90 minutes, so whether that's SIBO, whether that's the proximal colon, it showed really good relationship to symptoms of abdominal pain, to actually reflux symptoms like belching and regurgitation. And we've previously published some data on this a few years ago. So it just further reiterates that. It was closely linked to symptoms after eating, which again kind of makes sense in that the symptoms are in response to the foods that we digest, that we don't digest, and the bacteria break them down. And it's also linked strongly to skin conditions. We found that there was a strong link of this rise to eczema and rosacea, as well as chronic low ferritin. And then just touching back on what I mentioned in the second, what's going on in the second half of the breath test, when we see this excess fermentation with a rise of 60 parts per million or more, or what we're dubbing cecal malfermentation, so excess fermentation in the cecum, we see that it's strongly linked to abdominal pain and bloating, as well as, again, symptoms after eating, which kind of makes sense once that undigested food is being fermented. And also, again, a strong link to skin conditions in eczema, which is what we're starting to see with the gut-skin axis. And this data, again, from the Reimagine study, just really reinforces what we're seeing here. And they sequenced the small intestinal microbiome with patients with SIBO. And we can see that it's dominated by Escherichia and Klebsiella, which are mostly hydrogen producers. So in terms of treatment, at the minute, the most probably effective and safe treatment is rifaximin, but it still is only about 50% efficacious in patients. There are a few things that I think we can do to improve that not a lot of us are implementing. So firstly, rifaximin is activated by bile acid. So make sure our patients are on a moderate high-fat diet whilst they take this. We can also improve efficacy through a few other products that have been shown in clinical trials. So one being the prebiotic PHGG, or partially hydrolyzed guar gum. Now, this is a non-fermentable prebiotic. That's very important because obviously we don't want to be giving our patients with SIBO fermentables. And this has been shown to improve the efficacy of rifaximin when taken alongside. We can use a probiotic, but again, we want to be careful. We don't want to be giving them bacteria. There is some data to show that adding more bacteria can make symptoms worse, sort of like adding fuel to the fire. This is a strain of yeast. So yeast is obviously not a bacteria, and there's some good data to show that it can help to reduce SIBO. And then we have some recent data from last year in that adding a biofilm disruptor, so N-acetylcysteine alongside rifaximin, and also for 1 week before to start disrupting that biofilm that these bacteria are doing in the small, that are making in the small intestine, can help to improve the efficacy of rifaximin. And these are all very safe to take. And then lastly, we did have this study from a few years ago where rifaximin isn't available. We may be able to rotate antibiotics. So what the researchers did was they gave 10 days of an antibiotic. Then the following month, they gave another 10 days of a different antibiotic. And then in the third consecutive month, they went back to that first one for another 10 days. And we saw about 70% efficacy in treating SIBO using that. But as Malvina very nicely put on her last talk, these antibiotics don't come without consequences to the microbiome and to our commensals and good bacteria. So are there some more conservative ways we can manage our patients? Because we know ultimately SIBO seems, and the breath tests seem to return to normal, 6 weeks, 6 months down the line after treatment. So what we've been doing at FGC is a bit of a program in terms of how we can get that flare of symptoms under control. So the first thing would be to advise a low fermentable diet, and it doesn't necessarily have to be low FODMAP. Most of our patients will have probably tried this, but we already know what the key fermenters are, your fructans, your GOS, so we can just strip those back from the diet. We can add in something like an intestinal adsorbent. So these are not supplements, these are classed as medical devices, and the way they work is they basically mop up bacteria, toxins, metabolites, gases from the gut. And there's a really nice study from Enterus Gel a couple of years ago published in Gut, where they did a study in over 400 patients with IBS-D, and they saw that their intestinal adsorbent helped to improve symptoms of abdominal pain, bloating, as well as diarrhea. And then we can use things like digestive enzymes. So these can ultimately break down some of those FODMAPs or difficult to digest carbohydrates, making them less available to the bacteria in our gut to ferment. And we quite like Juvia. So Juvia contains enzyme-rich malt extract, and we did a study of this a couple of years ago. And the malt extract contains a high level of enzymes that can break down fructans. So fructans are probably the most problematic FODMAP found in things like garlic and onion. And we did this study in more of a constipated cohort and found that it was also able to improve symptoms like abdominal pain and bloating. But yeah, just touching on hydrogen and methane. So we've talked about hydrogen. We know that we get this rise as we get the fermentation of gases, but with methane, we don't see that because it's non-saccharolytic. It's not produced by fermentation. It's produced by archaea that utilize the hydrogen or acetate to produce methane. So it's normally high at baseline and remains high throughout the test. And in terms of symptoms, it's strongly linked with constipation and IBS-C. We know that. It's inversely linked with IBD. And some data from our HMBTQ study is we found that it's strongly linked to stools that float. And this might be because methane is actually much lighter than air. So if your patients report this symptom, perhaps a methane breath test could be useful. But then again, maybe not, because we've done some other data in healthy volunteers, which shows that actually 1 in 3 of them have high levels of methane. So is it quite normal to have this? Is there a switch that is flipped in some of our patients, which makes them, with methane more constipated, a bit like with H. pylori, whereas we know there's a lot of healthy people without symptoms who have it, but some may have a more virulent strain. So we would say only treat high methane if the patients are symptomatic. And in terms of treatment, we're very limited. All we have is this study which showed basically adding neomycin or metronidazole to rifaximin can improve eradication to rifaximin or neomycin and metronidazole alone. But what we see again, same old story, the methane comes back 4 weeks later. So again, if this is a normal part of the microbiome, do we need to stop worrying about that and just manage the constipation and bloating with things like diet and laxatives? Then the third and final gas that has been so elusive up until now is hydrogen sulfide. And hydrogen sulfide is a bit similar to methane in that it's not produced by saccharolytic fermentation. Basically, the hydrogen sulfide producing bacteria take the hydrogen in combination with sulfur in the diet and produce hydrogen sulfide. But why we think it's been so elusive is because we're detecting it in the parts per billion range. So hydrogen and methane are in the ppm or parts per million. And what we see in healthy volunteers is the levels of hydrogen sulfide is really low, about 4 ppb. But then in patients with symptoms, it's around 25. It kind of goes against some of the literature that's already out there, where they're measuring it in parts per million range. We think it's much more sensitive. And hydrogen sulfide is associated with diarrhea and IBS-D, also IBD, and it's got that characteristic smelly, eggy odor. In terms of treatment, again, we're very limited. There's some study from 25 years ago showing that bismuth in the form of Pepto-Bismol 4 times a day was helpful. Again, on cessation, the hydrogen sulfide comes back. We know this isn't really safe to take long term, so maybe it's something that we can implement, every now and again in our patients to provide immediate relief, and probably combine it with something like a low sulfur diet. So diets high in protein, meat, eggs. This increases hydrogen sulfide production, whereas a diet high in fiber reduces it. And then what about in patients with sort of refractory breath test, refractory symptoms? What can we do? Perhaps FMT. Now we know so far that meta-analyses don't support using FMT in IBS, but we have some studies where they look a little bit more at the gut microbiota, and we can see that actually there is an improvement in line with a reduction in hydrogen sulfide producing bacteria. And then one study that looked at FMT for SIBO saw an improvement. And we've just completed the phase 2A trial of EBX of their product in IBS-C and IBS-D. Maybe James can talk a little bit about this, or maybe he can't. We're not sure yet, but stick around because that is in the following talk.
Talk a little bit about it. I can't, talk about all the results and everything we found, but we'll get top line information. So hang on if you're getting tired.
Less than 5 minutes, I promise. We'll be talking about it. And this figure just nicely summarizes those sort of gut microbiome phenotypes we see in IBS patients. So in IBS-D, it's more of a hydrogen sulfide driven microbiome. In IBS-C, it's more of the methanogen driven microbiome. And this is sort of an algorithm that we've come up with at Functional Gut Clinic. And again, just saying that in these patients that present with symptoms, once the red flags have been ruled out, we can probably start with some of the conservative treatments like the low fermentable diet, probiotics, prebiotics, intestinal absorbents. But if they're not responding or they've already tried these, maybe we want to escalate to testing. And based on the type of gas and rise that we see on testing, we can use targeted treatments. But then what we want to do is keep these patients from flaring again. So we put them in this repair phase where we put them back on the low fermentable diet using some adjuncts with the intestinal absorbent and enzymes. And then after they've done that for about 4 to 6 weeks and the microbiota is settled and fermentation is reduced, can we give them things like probiotics, prebiotics, fermented foods, even FMT to try and replenish that microbiome? And I just want to revisit this slide before we come to the last couple of minutes of the talk. And we've mainly just covered gases so far. And there's this cauldron of metabolites that we can look at. And the area that we're mostly interested in is the cecum or the proximal colon, because this is the most important area when it comes to bacterial fermentation. Because there's a lot of bacteria, there's a significant increase in bacteria here from the small intestine, and they're breaking down our undigested food, and that they produce nutrients that we extract. It's essentially a form of secondary digestion. And at the minute, there's no really good way of looking at this. Stool microbiome testing can't really tell us anything about this. And this just reiterates why we've been interested in it for so long. So over 10 years ago, Professor Hobson did a study using SmartPill, which measures pH, in patients with IBS. And what they saw was that in patients with IBS, they have a lower cecal pH, which is because of all of the excess fermentation. You imagine things like short chain fatty acids that are being produced. These are acidic. They lower the pH in the cecum. And what happens is when you put those patients on a low FODMAP diet for a month and re-challenge with the SmartPill, you can see that actually the pH has increased. It's no longer as acidic, which means there's less fermentation, and the microbiome of the cecum has probably changed. And this correlates really well with an improvement in IBS symptoms. So can we look at this area with breath? And this is one thing we're really excited about, because in partnership with Owlstone, we've been able to use things like the SIFT-MS to look at some of these trace gas elements in real time, so hooked up to the machine or using collection bags. And so far, we found over 530 different volatile organic compounds that could be related to the gut microbiota on breath. So how do we know they're from the gut microbiota? Well, what we're going to have to do is start to use probes. So we've done that. Well, one of our PhD students has been looking at that over the last few years by initially in a healthy volunteer cohort, giving them iron and a lactulose provocation challenge. So we know that iron in about 70% of people who take it end up with GI symptoms. And we know lactulose is a non-digestible sugar. So it's going to arrive to the cecum. It's going to be metabolized by the bacteria there. We're going to see something. And what we've seen so far in terms of the microbiome, it doesn't really change much. That's kind of expected because in healthy volunteers, their microbiome is pretty robust. But what we wanted to do is understand the feasibility of doing something similar with VOCs in breath. So can we get like a vocome and look at the diversity and abundance? And we can, but again, it seems to be relatively stable even after we give them something like iron. And that's just because probably healthy microbiome metabolome is pretty stable. But what we can do is more targeted analysis. When we look at things like short chain fatty acids, in this case, butyrate, we saw that actually we see an increase in butyrate both with the lactulose challenge and following the iron supplementation. And again, we saw something similar with propionate, which is another important short chain fatty acid. And here we're sort of mapping those VOCs again, like we do with the stool microbiome. And the goal is to try and pick some of these out and see which ones are sort of, changing in our patients, and can they, again, predict things like responses to treatment. So last slide, future diagnosis, we think breath is going to be super helpful in terms of telling us what the microbiome is doing, so the metabolome, and we can use different probes, look at it in response to different treatments like diet and medications. There's also a couple of cool capsules coming out, one that might be able to help us look at the small microbiome, or one that actually measures gas throughout the intestinal tract as well. So in summary, stool microbiome testing is limited clinically in terms of what we can recommend from a stool microbiome test is very broad and vague. It's usually just eat more plants. Breath testing is much more useful clinically because we can actually use targeted therapy based on the gases that we see. And dysbiosis, we know can actually be managed conservatively. We don't have to use antibiotics in the first instance. We have these conservative means from that protocol that I showed you that we're using. And again, as Malvina touched on, we don't want to be just bombarding our patients with antibiotics and ruining the gut microbiota in the long term. And the future of the gut microbiota testing, at least, is understanding what they're actually doing. So thanks. I know it's getting late. If we've got time for questions now, if not, happy to take any at the end.
Thanks so much, Jordan. It's an absolute whirlwind through what is quite a complex area. But I think the important thing is that we do have now some fairly simple, non-invasive tests that are actually actionable. And I think what we want to do now is try and build a community of people who do test in the same way, who treat patients in the same way, who collect symptom data pre and post testing, and collect outcomes data and start to build the evidence base. And I think you'll all hear more about that as we start to do some in-person training events in the future. So, I think it's safety in numbers in terms of us all getting together and trying to, do the same thing in our patients and try and build the evidence base. But in the interest of time, Jod, I will pass on to James. James and I first met in about 2017 when he came to Manchester, and James had a dream. And we spoke about, what studies he might want to do in the future. And then James went away. And that dream has come to fruition. And, he's done an amazing amount of work. And we've been lucky to be working with him in the last year or two in doing some clinical trials. But I'm going to pass over to James now to tell us about the amazing work that he's been doing at Enterobiotics.
Thanks, Anthony, and thanks, Jordan and Malvina, for a really interesting evening so far. Just a couple of disclosures. I'm employed by Enterobiotics. I hold shares in the company as well as share options. And in terms of disclaimer, we will be talking today about an investigational drug product called EBX-10202. It's our company's lead asset. It's not approved for use in any regulatory authority in any jurisdiction, and any references at this point in time relate to its development in a clinical research setting. And none of the information is intended to be promotional, and nothing is intended to constitute the practice of medicine. So at the dawn of the new millennium, President Bill Clinton stood up and announced to the world that humanity had reached its greatest ever scientific achievement. We had sequenced the human genome. And if you go back and watch him talk, you'll hear he makes some pretty big forward-looking statements about what the future will look like. And I've pulled out my three favorites on this slide. He said, without a doubt, this is the most important, most wondrous map ever produced by humankind. In the coming years, doctors increasingly will be able to cure diseases like Alzheimer's, Parkinson's, diabetes, and cancer by attacking their genetic roots. Finally, it is conceivable that our children's children will know the term cancer only as a constellation of stars. Here we are, 25 years later, and I think it's fair to say that those dreams and that vision hasn't yet become a reality. And of course, there's a second genome within the body, one that wasn't highlighted by President Clinton or these other scientific experts at the time. And that is our gut microbiome. So what we've heard about today is that the gut microbiome is fundamental to human health. We've heard that there are lots of microorganisms that live on and inside of our body. The number of microbial cells is broadly even to that of the number of human cells. The more interesting figure for me is the difference between the number of microbial genes within your gut microbiome versus your human genes. There's at least 1,000 times more. So 20 million microbial genes, some estimates suggest even larger. And the question I'd like to pose to the audience, which is clinicians, is could our environment be driving changes to the second genome? And could that be the driving force behind the chronic disease that we see today? So over the last few decades, society, the world has become cleaner, but we see more and more in the way of incidents of immune-related disorders. And what's really interesting and exciting and segues into my presentation today, which is about the future of microbiome medicines, is that in contrast to the human genome, the second genome, the gut microbiome, is inherently modifiable. And that paves the way for microbiome therapeutics such as those that are being developed by Enterobiotics, because this is a druggable therapeutic target. So what I want to highlight today is basically a number of reasons to believe. I'll give you some evidence and some hard data, and then give you some visions for the future as well. But before we get into that, I'd just like to start with 3 reasons to believe in the future success of microbiome medicines. So the reason number 1 that we should be believing is clinical validation. 30 years ago, 20 years ago, even a decade ago, it was still super early. We had lots of correlative evidence, but very little in the way of hard proof and causation. The position that we're taking at our company, and the case I'm going to make today, is that intestinal microbiota transfer, also known as fecal microbiota transplantation, is a robust treatment, and there's been robust efficacy demonstrated across a range of randomized double-blind placebo-controlled clinical trials. So strong, in fact, that it features in the treatment guidelines and consensus guidelines around the world. We now have a supportive regulatory environment. We have collaborative relationships with a regulator who wants to see innovation in the microbiome space. And as a consequence, and as a result of that, there are multiple ongoing academic and industry-sponsored clinical trials for a variety of different modalities, and we hope that they generate positive impact for patients. The third pillar is that there's a strong industry and academic pipeline of innovation, and I'm going to talk about this today. There are approved microbiome drugs in the USA. I imagine that they will follow in the UK and Europe shortly thereafter. There's significant grant funding awards and investment being made in the microbiome space. And as you'll hear about later, there is a deep pipeline coming from the industry of innovative approaches. And our aim is to partner with you all as the clinicians to translate these innovations into tangible benefits for our patients. In 1958, the chief surgeon at Denver General Hospital, a man called Mr. Ben Eisman, was faced with a situation that he'd sadly seen many times before. 4 of his patients were acutely unwell with heavy diarrhea, stomach cramps, high fever, and to be honest, were moving towards being on death's door. But Mr. Eisman was an innovative surgeon, and he postulated that the antibiotics that they were giving were maybe doing more harm than good. And he had a thought, an innovative idea. What if we move microorganisms from the intestinal tract of healthy people into the intestinal tract of these patients? Maybe we could somehow suppress the bad bugs that are causing the problems. Now, what we now know is that these patients were suffering from recurrent C. difficile infection, and this is the first recorded case in modern medicine of an intestinal microbiota transplant. And we have a lot to thank Mr. Eisman for, because that was the catalyst for what has now become a very large evidence base and really was the start of microbiome medicines more generally. So over the last 60, 70 years, there has been a huge increase in the number of clinical trials that have investigated intestinal microbiota transfer for a variety of different disease indications. And on this slide, I've summarized how the evolution has progressed. It started in C. diff and ulcerative colitis, and now it's progressed to a variety of different patient populations and disease indications. And the key takeaway here is that there were 12 studies listed on clinicaltrials.gov in 2013. And the last time I checked, a couple of days ago, there were over 500. So there's lots of reasons to be excited for our patients and also for clinicians working in the space in the context of INT. So where does the evidence base sit then more generally? Well, there's been well over 100,000 FMTs performed globally. That's robust, objective, quantifiable data. It features on the treatment guidelines in the US and across Europe for recurrent C. difficile infection. We're seeing consensus guidelines published now for ulcerative colitis, and it won't be long before we see it in other patient populations. The most interesting piece across all of this is that it seems to be a well-tolerated procedure. Most adverse events are mild, self-limiting, gastrointestinal nature. There have been some adverse events, to be clear and to be fair, but they've related to inadequate screening of starting material, which is stool, or the procedure itself, like the colonoscopy or a tube that goes into the second part of the small intestine. And there have been efficacy signals. Jordan mentioned that the meta-analysis in IBS was inconclusive, and it's true. When you pull together lots of the data from different studies, the data is, in many cases, inconclusive, but there is definitely a strong signal. And it's that strong signal that the industry are picking up from and then developing more refined, standardized drugs with the aim of getting approved products. I also want to highlight another point. We talked about engraftment, or the persistence of strains after taking a probiotic. And the view that the experts took at the start was, essentially, if you're taking a probiotic that you can buy off the shelf, it's classically a strain or a species that's come from cheese or yogurt, and as such, it's not naturally adapted to the microbiome, and it usually passes through like a passenger. It may confer health benefits, but it usually doesn't find a home. One of the key strengths of FMT or IMT is that you're moving microorganisms that are living happily inside of someone else's intestinal tract into the intestinal tract of a patient that typically has some niches because they've had antibiotics or because they've had other microbiome disrupting events. And what we're now seeing in the literature is we are correlating the phenotype of interest, so some sort of clinical response, with engraftment data, and we're starting to unlock mechanism of action as well, which is important. I mentioned that there are 2 approved drugs in the US. Just a quick overview of those. You may not have heard about this before. One is manufactured and distributed by a company called Ferring. It's an enema for recurrent C. difficile infection called Rebiota. The other is a product that was developed by a company called Ceres Therapeutics. It's now been taken on by Nestlé Health Sciences, and this is an encapsulated formulation, again, for prevention of recurrence of C. difficile infection. So another key take home for the audience is that the FMT studies started in 2013. It takes roughly 10 years to develop a drug. And indeed, 10 years later, there were approved products for C. difficile infection. So one of the points I would like to make is that we're now seeing efficacy data for IBS, ulcerative colitis, potentially Crohn's disease, and a variety of other indications, maybe even diabetes and metabolic syndrome. So the prediction is that 10 years after those studies, we should start to see microbiome therapies come to the fore and come to the fruition for patients and clinicians. Now, just a note on ulcerative colitis, because this is probably where the strongest evidence base exists for intestinal microbiota transfer outside of C. difficile infection. There have been 9 randomized controlled clinical trials published to date in patients with UC. All of them have been in patients with mild to moderate clinical status. There are at least 18, potentially more, further clinical studies that are ongoing in the clinical trial pipeline. What's interesting, and you should take a look at this most recent article published by a group working in Rome, it's a consensus statement about what future studies should look like in IMT, in UC, and also where the gaps are. But what they also did was basically pull together all the studies. And you can see in the second column here of this infographic produced by the authors that there are some real hits in terms of efficacy. And even where there's a cross, because it hasn't met a pre-specified statistical outcome, you're seeing a signal associated with FMT. Another key point is that some studies mix together donations from different donors and have donations from singular donors. And in some of the studies with singular donors, one donor out of the pool seems to be driving most of the phenotype of interest. So there may be something in here as well about donor-patient compatibility Or is there something special about that donor, like they have very high diversity or enhanced short-chain fatty acid production that might be driving the phenotype of interest? One of the other points that I'd like to make in this talk today is that there are a number of lines of evidence that link the gut microbiome to improved outcomes in cancer. And I think this is going to be a big topic of interest for both the industry and also scientific academic research looking forwards into the future. So reference point number one is that the microbiome diversity strongly correlates with graft versus host disease mortality. So if you have higher diversity, which is a proxy for health, as you've heard from Jordan and Malwina, you have a lower chance of dying after a hematopoietic stem cell transplantation. Furthermore, microbiome diversity more generally correlates with overall survival after this procedure. Why is that? Maybe you have less in the way of pathogenic microorganisms, you maybe have enhanced gut barrier function, and there's definitely something going on with the immune system, which we'll talk about in the subsequent slides. And finally, there's a higher response rate to immune checkpoint inhibitors in metastatic melanoma. So if you have higher diversity, you have a higher chance of response. Now, if I take you back to the start of this presentation, I talked about moving from correlation to causation. So we've heard about the correlation. What about the causation? Well, in our opinion at Interabiotics, and my opinion personally, the best causative evidence, so to speak, is driven by the fecal microbiota transplant IMT studies across a range of indications, because it is, in a sense, proof of concept. It is the most dramatic, rapid, and arguably sustained way of changing your microbiome. Within 72 hours, there is classically a complete remodeling of your structure and function, particularly if you have a very depleted microbiome after chemotherapy, antibiotics, or some other medical intervention. So the team that we're collaborating with at Imperial have published some data showing that there's higher overall survival after allo-HSCT in patients receiving IMT. Their thinking is you can precondition the gut prior to getting all of this deleterious medical interventions in the way of chemotherapy and some cases total body irradiation, and prep the microbiome and prep the body to do better after the stem cell transplant. And we're collaborating with Imperial on a phase 2 clinical trial sponsored by the Medical Research Council. We've currently enrolled over 25 patients, and we hope to announce that data within the coming years. So we're excited about that. Two other pieces of exciting evidence. So there were 2 studies published in the journal Science back-to-back in 2021. And immunotherapy has been a game changer for cancer patients. There's no doubt about it. And what happened in these studies is in patients with metastatic melanoma who were non-responsive to immunotherapy, they moved microbiomes from patients who were responders into their intestinal tract. And in both of those studies, the fecal microbiota or the intestinal microbiota from the immune checkpoint inhibitor responders induced clinical responses. In some cases, total remission. So outstanding clinical results. And there you have the causation, because you're moving a microbiome from a responder into a non-responder and delivering a response. So it's direct evidence that changing the microbiome through a full ecosystem approach can have a profound impact on an immunotherapy outcome. So as a result of that, lots of investigators are now looking at IMT, FMT, and there's a variety of companies also pursuing approaches aligning to that. So basically watch this space. The other thing that I want to talk about in the field of cancer is that it's likely, based on FMT studies and tyrosine kinase inhibitors, that you can improve the tolerability of your cancer treatments through microbiome conditioning through an IMT or other approaches. So if you can withstand the current standard of care better and for longer, then you're likely to do better in terms of your cancer. So having said all of that, IMT has a lot of potential, but it remains largely unexploited. Potential has not been realized. Why is that? Well, sorry for the graphic image. It is past dinner time for everybody, but there are historical obstacles and opportunities to overcome. So classical FMT involves a one donation to one product type system. Literally, it's a stool sample that's classically processed in a blender. It's stored at -80 degrees. It's delivered as a brown liquid in a slurry. It has unpleasant physical characteristics. It's really difficult to undertake placebo-controlled clinical trials. And there's also potentially some safety concerns associated with just screening the donor rather than screening the product. And Anthony mentioned that I had a dream. And I did have a dream. I still have a dream. And that dream is to overcome all of these obstacles through a drug product that is consistent, scalable, patient-friendly, and that ultimately, we hope, drives profound impact in clinical studies. So the whole aim and ambition at Enterobiotics is we want to capture all of the beneficial elements of a fecal microbiota transplant in an orally administered capsule that's got robust stability profile, that contains the beneficial elements in an off-white color, odorless powder. It's convenient for patients. It has consistently high microbial diversity through the platforms and the technology that we've established at the company. Best-in-class pathogen screening. And as you heard from Jordan, he gave a little teaser, we are seeing some highly encouraging early clinical validation in our clinical studies. So we've completed a phase 1b clinical study, randomized double-blind placebo-controlled in patients with liver cirrhosis, and announced positive data. And we've also completed enrollment in an N=122 clinical study that we delivered in partnership with Professor Hobson and the good team at the Functional Gut Clinic. So in this study, patients with confirmed IBS through the Rome 4 criteria were randomized to receive either EBX-10202 or placebo. Patients were given 8 capsules, 2 administrations, 7 days apart. So 8 capsules on day 1, 8 capsules a week later. The primary objective was to establish safety and tolerability because there have been some issues with the IBS studies in the past, insofar as you had mixed patient cohorts, unclear outcomes, the intervention was not clearly defined, and sometimes there were not robust placebo controls as well. So we wanted to deliver a very robust study that generates a clean safety and tolerability profile, and ideally gives us some efficacy signals that we can then use to develop further in later stage studies. So our company made a press release 2 weeks ago where we announced positive top-line results. We demonstrated clinically meaningful superiority over the placebo and key efficacy assessments. Patients, as I mentioned on the last slide, had IBS confirmed through Rome 4 criteria. They were moderate to severe based on the IBS symptom severity score. The drug was well tolerated. The adverse events were mainly mild, self-limiting, and gastrointestinal nature. There was no severe diarrhea reported, and there were no serious adverse events. We did undertake shotgun metagenomic sequencing and breath testing. So there was a hydrogen methane breath test, as well as hydrogen sulfide breath test for the IBSD patients. And we identified that there were significant shifts in the microbiome. So there is evidence of engraftment of our strains. And what we're now doing is correlating that engraftment to some of the efficacy outcomes. And I was happy to see this nice positive quote from Anthony on the slide. So over the course of the remainder of this presentation, having now discussed IMT and discussed the work that we're doing at Enterobiotics, wanted to just highlight some of the other approaches that there are to modulating the microbiome being driven by the industry and some key trends. So one of the concepts that I think is really important to take away here, although I've been talking about the drug approaches and the pharmaceutical approaches to modulating the microbiome, I think it's fair to say that food is a medicine. And there's a variety of different approaches you can use through food to deliver medicinal type benefits. I'll give you one direct example. For the gastroenterologists who are treating pediatric patients, you'll be very familiar with exclusive enteronutrition. It is as effective as steroids and immunosuppressive medication for clinical improvement. So when patients start their course with newly diagnosed Crohn's disease, you see 60 to 80% remission after 8 weeks. And that is a direct microbiome modulating dietary change that has a significant impact on clinical symptoms. And I'm highlighting here on this slide some work from a team in Glasgow that we've collaborated with at Enterobiotics, where they're trying to replicate the benefits of the entirety of the liquid diet with a food-based diet, so it's less restrictive for patients. And what we're going to see over the course of the coming years is more of this personalized, tailored dietary intervention to improve symptomatology in patients. Jordan mentioned low fermentation eating, low sulfur eating. There's going to be more of that for other GI diseases in addition to IBS. What we've not talked about much today is the rising popularity of at-home microbiome testing. It is going a bit crazy. There's lots of people bringing in lots of reports to their physicians. There's a whole range of companies to choose from, and some of them are making some pretty bold claims about what their tests can show. The most recent consensus statement on this from a variety of leading clinicians who are interested in the microbiome space and gastroenterology basically said, It's interesting for patients to go and profile their microbiome. The diversity metrics are potentially of interest as well, but it has limited value in the absence of repeat longitudinal testing. And at the moment, there isn't much we can do with the reports in terms of actionable clinical insights. And I think that mirrors what Jordan was talking about earlier. So what about the remainder of therapeutic approaches then? So basically, there's two different ways of classifying this in our opinion at our company. There's the bugs as drugs, which are live biotherapeutic products. Then there's the non-bacterial microbiome modulating agents. And within the bugs as drugs, you've got your individual species. They can be naturally occurring or they can be engineered. Another key takeaway for the audience is that historically, the single strains have been those that are easy to culture and stabilize. Ones you find in cheese and yogurt, like lactobacillus and bifidobacillus, as you heard from Malvina earlier. What's now happening is people are isolating microorganisms from the guts of patients, matching those strains with phenotypic properties like short-chain fatty acids, and growing and stabilizing those. They're much harder to grow and stabilize. So these are quote unquote next generation probiotics or next generation live biotherapeutic products. Some companies are going a step further in engineering those to deliver specific payloads, but they're a little bit earlier in clinical development. There's consortia, so these are mixtures of different bugs, and they can be donor dependent, like the drugs that Enterobiotics is developing, or they can be rationally designed and constructed. So consortia of strains that are put together based on specific properties, like, for example, regulatory T-cell induction. You then have your precision microbiome modulators like phages, so viruses that infect bacterial cells. You've got your postbiotics, short-chain fatty acids, and then you've got prebiotics and medical foods. Now, I'm not going to go into all of these in detail in the interest of time, but I felt it was appropriate and fair to give an overview of the entirety of the landscape. And just very briefly, I mentioned at the start that there was a really deep pipeline of innovation. This slide here highlights the overview of the bugs as drugs landscape today. And most of these companies will be looking for clinicians to partner with in their clinical trials. And this is exciting for me because all of these companies have a slightly different approach. Not all of them are going to succeed, but if only a fraction of them succeed, then we should have new therapies to give patients who are currently suffering from unmet medical needs. And I think that is very exciting. I've given my impression on this slide here of the status of different therapeutic approaches. The key take home here is that the furthest advanced are the consortia and the full spectrum products, like the ones that Enterobiotics are developing. There have been some failures. It would be wrong for me to stand here or sit here and say that it's all been rosy. It hasn't. The field has been through many ups and downs. But typically what happens with new modalities and new technologies is it's not the first companies that ultimately are the most successful. It's usually the fast followers. And what you're now seeing is the second and third generation microbiome companies coming through, generating robust clinical readouts. And this year, we're expecting at least one phase 2 readout in ulcerative colitis and a couple of phase 3 readouts as well in graft versus host disease and potentially others in cancer. So just to conclude, I'm going to give some vision thoughts for the future. So I think that the future microbiome medicine will involve next generation microbiome therapeutics. And these are going to move from C. difficile infection to IBS, inflammatory bowel disease, and immune-related disorders. We're going to move beyond the drug working to the drug working and understand how it works. So the integration of the omics, the breath testing, the longitudinal testing that Jordan was talking about. There's absolutely going to be a microbiome oncology convergence. It's happening right now. And I predict that there will be enhanced response rates to immunotherapy and also reduced toxicity and therapy-related adverse events. So this is good news for everybody because all of us have been touched by cancer at some point. Microbiome diagnostics are going to become routine. You've heard the pitch today from Jordan. I think it was great. Pairing the breath test with functional metabolomic panels and longitudinal testing with multidisciplinary team input to guide therapy and nutrition is where I think it's going to go. So patients will come in, they'll get their microbiome profile, they'll get their breath test, something changes, then they come back in and you monitor response in that way. We've not talked much about AI and machine learning, but this will enable patient stratification and ideally the simulation of host microbiome drug interactions, which will accelerate drug development. And the final prediction is that the next generation probiotics will replace most of the first generation probiotics because they have a defined MOA and they will have true health benefits and a higher probability of success for engraftment. So with that, I would like to thank you all for your attention. I'd like to thank Anthony for the opportunity to come and present, and happy to take some Q&A if we've got time, although it does look like we're running a little over. Thank you very much.
Thanks so much, James. I mean, that's just mind-blowing. And I think, when I started and kind of gave that Brian Cox analogy of like, isn't space unfathomable? I think what you're showing us there is that actually it's starting to become fathomable, actionable, understandable. And, it's almost like a space exploration mission, isn't it? I said at the beginning that the market for simple probiotics, prebiotics, and supplements is about $13 billion a year. I mean, what is the projection from the pharma industry of where this could go in the future for these kinds of microbiome modulatory therapies?
Well, I mean, the best-selling immunotherapies are selling close to that standalone. So, if you can potentiate the efficacy of a drug that's selling that well, then, you can imagine the size of the market opportunity. I've seen statistics suggesting that, potentially 100 billion plus is the size of the opportunity. And I really believe that. If you think about all the diseases, conditions that the microbiome influences, if all of those are druggable in some way, shape, or form for patient benefit, then there's an opportunity in all of those. So feel very optimistic about the prospects of pharmaceutical and drug development in the microbiome. The key will be robust clinical data that's reproduced across sequential clinical studies, and then convincing the payers, physicians that this is the right thing to invest their time in. But, since we first met, the field has transformed. We have moved from these kind of very early phase clinical studies with signals to robust, large, statistically powered clinical studies. And that's where I think things are going to go looking forwards.
I think the interesting thing from Jordan and Malvina's talks as well is there's this kind of digestive health continuum from people who just want to be a better, more robust version of themselves and prevent them developing disease, from people who have mild disease and want to be brought back into normality, all the way through to people with severe disease. And it seems now there are algorithms and approaches and objective evidence that people can start to kind of adhere to and then choose at what point they need to escalate up or down that spectrum. Is that how you see things going for patients? I mean, you touched on it briefly there at the end about, whether it's home testing or breath testing or whatever. Is that how you see it going? People sort of driving their own pathway?
I mean, my own personal view is I think pretty much everybody in the Western world has got a compromised microbiome in some way, shape, or form. And everybody can benefit in some way from taking control of their gut health. So you talk about the 3 Ps, prebiotics, probiotics, polyphenols. That's almost ubiquitous, I think, for everybody, even if it's probiotics that you find in food rather than being a probiotic supplement. And then I think, for patients, I liked your reset, restore. I love the algorithm. I think that's great. I've heard weed, seed, feed, which is like a garden analogy. So there's a lot of different people, I think, saying the same thing. And it doesn't matter who you are or what you do. If you make a commitment to change your diet for the better and have more of the prebiotics, polyphenols, probiotics, you're likely going to feel better and you're likely going to have an impact. But some people have gone too far down the road, and that's when they need the medical intervention. That's where they need the testing that you guys are offering, the probiotics that Malvina's offering, and then eventually when our drug becomes approved, I see a full spectrum approach fitting into that pathway as well, for sure. And
just to bring Malvina in here briefly before we finish, I mean, in gastroenterology, there are 3 common treatments: antibiotics, PPIs, Helicobacter eradication, all of which are fairly, and bowel prep, of course, all of which are fairly destructive for the microbiome, but seem to be a secondary, thought to clinicians. Do you think there's a role in education to start, teaching primary care, secondary care physicians that before they embark on these treatments, either to try more conservative methods or actually have some prevention to reduce the long-term effects on the microbiome?
Absolutely, and through different channels and different charities, including the Nutrition Society, we've been trying to promote that to include more nutritional sciences and microbiome-focused information in the curriculum. But it's very difficult to push on the agenda of the national program. So at the moment, it's all small activities like this webinar to encourage people to just think about it and consider. But also, let's not forget that this is how things look in UK. If we look at mainland Europe, in lots of countries, actually this protective mechanism where some form of microbiome protection is administered to patients on antibiotics has been a standard practice since I was a child. And it's normal to give probiotic product alongside antibiotics, something that is not being practiced in UK. And in many countries, those changes to microbiome also occur for various different reasons. We're very good in UK with trying to reduce the amount of antibiotics and the antimicrobial stewardship, but we don't protect microbiome alongside. We don't protect it by reducing in other treatments that, like you mentioned, PPI, no one ever thinks that it's going to have a direct impact on microbiome. And the benefit that is seen from using long-term PPI seems to be better than what they cause to microbiome. But what we will see is downside of it in 10, 15, 20 years. So I think in line with what all of us are saying and trying to treat all of the people who are ill now and recover the microbiome that has been lost, we're all missing one tiny component, which is educate people who have children to protect and develop their microbiome to be strong and resilient from the outset, so that when they are grown-ups, when they encounter illnesses, they have a strong, rich, diverse microbiome that can protect them and can be better starting point than we have at the moment, because that's something that's a completely separate talk focusing on pediatrics. But I think this is also a very important element when treating kids to remember the long-term effects.
So we should all be cryogenically freezing our children's microbiome so they can use it in later life. Is that what you're saying?
Well, funny you said that because we've been discussing that with colleagues recently. And actually, it's not a bad idea. There's only one question. At which point you're going to be at your prime microbiome? And which sample is the one to choose to be the one that you would then use to reseed?
Yeah.
Well, on
There
that
are
note,
companies, I was going to talk about companies offering that, but about not. I think that's a good note to finish on, isn't it?
so thank you so much to all the speakers and the attendees. Obviously, we had a huge number of registrants for this, so we are recording this, and it's going to go send it out as a link, and then we'll get some feedback from everyone about it. If people do have questions that they want to pose to the speakers who watch this offline, then please do email it to Anthony Hobson at thefunctionalgutclinic.com, and I will try and get answers for you. So sorry it's run over a little bit, but I think it was well worth it. Thank you once again, everyone, and have a good evening.
Thanks,
you,
everyone.
everyone.
Thanks for listening and your interest in the microbiome. Appreciate it.
Thanks all. Bye bye.